65-year-old female with pain lower abdomen and discharge per vaginum. So, 65-year-old female postmenopausal reported to the gynae department with the chief complaints of discharge per vaginum and pain lower abdomen since the last 6 months. She had excessive vaginal discharge which was odorless, colorless and watery, and pain lower abdomen in the suprapubic region which was mild, intermittent, spasmodic and relieved spontaneously in a few minutes with no aggravating factors. There was no history of bleeding per vaginum, no history of itching and no bowel or urinary complaints. The patient was a para-3 Life-3 with all full-term normal vaginal deliveries with last childbirth and tubal ligation 37 years ago. There was no history of long-term use of oral contraceptives or of hormone replacement therapy. The patient achieved menopause at 49 years of age. Her past menstrual cycles were regular and there was no history of postmenopausal bleeding. Patient had no history of diabetes or hypertension. There was history of surgery for lump in both the breasts at 45 years of age. The histopath report for the same showed benign fibroadenoma. The family history was significant. Mother died of an endometrial cancer. One sister had history of esophageal cancer. One sister had history of breast cancer. One sister died of liver cancer and one brother died of an unknown cancer. Now, to summarize the history of the patient, the key features are a 65-year-old postmenopausal woman with odorless watery discharge and pain lower abdomen since the last 6 months and a strong family history of various cancers. Now, based on the history, I would like to ask the audience the differentials that come to their mind. Okay, you've taken almost all of them. We have main 4 causes: senile causes, infections, fistula and neoplastic. The senile causes include atrophic vaginitis and endometritis, infections like endometritis, vaginitis, cervicitis, various fistula and various neoplastic disorders. Now, let's see the examination of the patient. On general physical examination, the patient was conscious, well oriented to time, place and person, afebrile, pulse rate was 78 beats per minute, BP was 130 by 72 mm of Hg, respiratory rate was 20 per minute, saturation was 98% on room air, there was no lymphadenopathy and BMI was normal. The systemic examination revealed no significant findings. On per abdomen examination, on inspection, there were no prominent veins, no scar marks or lesions were seen. On palpation, there was no mass palpable, the abdomen was non-tense and non-tender, and there were no significant findings on percussion and auscultation. Now, as per the protocol, a gynecological examination was done, which revealed vulva to be healthy. On per speculum examination, vagina was healthy, cervix was healthy, flush with vagina. A thin, watery, odorless discharge was seen from the os. There was no fistulous opening over the anterior vaginal wall, and pap smear was taken. On per vaginum examination, the cervix was firm, regular. Uterus was bulky, anteverted, firm and mobile. Fornices were free and non-tender. On per rectal examination, rectal mucosa was free. Now, to summarize the history and examination, we have on examination no tenderness or palpable mass per abdomen, watery odorless discharge per vaginum which was not blood tinged, there was no vaginal fistula, no cervical erosion or growth and no fornicial mass was felt. Now, after the history and examination, various differentials are ruled out. Let's see about them. I would like to ask the audience what all differentials they can think of that are ruled out on the basis of was normal and there was no inflammation. Atrophic vaginitis is ruled out. Since the discharge was odorless, watery, therefore infections are ruled out. The fistulous opening, there was no fistulous opening on the per speculum examination, therefore fistula are ruled out. So we are left with atrophic endometritis, which is less likely, and the neoplastic causes like CA endometrium, which is likely. Since no fornicial mass was palpable, the CA ovary is less likely. There was no growth or erosion on first speculum examination on the cervix. Therefore, CA cervix is less likely, and CA fallopian tube is very rare but a likely cause. Now let's see about the investigations. Routine investigation like CBC and RBS were advised, which were within normal limit. Pap smear was taken, which came out to be negative for intraepithelial lesion for malignancy. A high vaginal swab was taken for culture and sensitivity, which came out to be sterile. CA125 was within normal limit. Other routine investigation like LFT, RFT, electrolytes were advised, which were normal. Viral markers were negative, and chest X-ray showed no significant findings. Now, the patient had a USG whole abdomen and pelvis. An outside report was available. The report showed USG upper abdomen, no significant finding was, there was no significant finding. Uterus was normal in size. Endometrial thickness was 24 mm. A heterogeneous cystic lesion in the endometrium anterolaterally on the left side measuring 30 mm, and bilateral ovaries were normal. The impression given was cystic endometrial hyperplasia. Based on this, a provisional diagnosis was made, which was a 65-year-old para-3 light 3 postmenopausal female with focal lesion in the endometrial cavity with endometrial hyperplasia. Based on this, a diagnostic hysteroscopy was done, which is the gold standard investigation in endometrial hyperplasia. The findings were endometrial hyperplasia, a sessile, extremely vascular endometrial polyp of approximately 3 into 2 cm was seen on the left anterolateral wall. An endometrial biopsy was taken, which was sent for the histopathological examination. Here is a video showing the hysteroscopy that we did. Here you can see tortuous vessels which projects to the high vascularity of the endometrium. The endometrium is thickened, as we can see. A polyp is seen. Here you can see the polyp. And finally, you can see us taking an endometrial biopsy. The histopath report that was sent was suggestive of a serous papillary carcinoma. Now, based on this, a MRI was advised to assess the invasion into the myometrium. Now, I would like to call upon Dr. Karan Jiani to shed light on the radiological findings.
Thank you, Dr. Praveena. Good morning to all the respected teachers, seniors, and fellow colleagues. I would like to begin with the images from the transvaginal ultrasonography which was done outside. There we can see the uterus and the endometrial cavity which is distended, showing a heterogeneous cystic lesion within it. On color Doppler, peripheral vascularity is noted without any significant internal vascularity. And the diagnosis which was given was cystic endometrial hyperplasia. For further evaluation, MRI of the pelvis was done in the Department of Radiodiagnosis at Mahatma Gandhi Hospital. This is a situated axial section of the pelvis. Here we can see the uterine myometrium. The endometrial cavity is distended and filled with fluid. Fluid levels are also noted. There is a polypoidal lesion within the endometrial cavity, seen in the non-dependent position with few cystic components within. Right, there is a small cyst in the right ovary, otherwise bilateral adnexa are unremarked. On the corresponding D1 section, hyperintense fluid is seen in the endometrial cavity and which appears bright, suggestive of hemorrhagic contents. On the T2 sagittal section, you can see the polypoidal lesion is seen arising from the anterior wall of the endometrium and the lower uterine segment, which is encroaching towards the internal os. On these two weighted coronal images, the findings, previous findings are consistent in this image, and on the basis of the above findings, MR features are suggestive of endometrial polyp with hematometra and no definite myometrial invasion.
And what about lymph nodes? I think that is another important thing which we look at, right? No lymph nodes.
Now I would like to call Dr. Garina.
The endometrium and no myometrial invasion was seen. It was endometrial carcinoma stage 1A. But for final diagnosis, we have to go for surgical staging, and hence a laparotomy followed by total abdominal hysterectomy with bilateral salpingo-oophorectomy, infracholecomantectomy, pelvic lymph node dissection was done. The para-aortic lymph nodes were also evaluated. The gross specimen comprising of uterus, bilateral fallopian tubes, ovaries, omentum, and pelvic lymph nodes and peritoneal washings were sent for histopath examination. Now I would like to call upon Dr. Shikha Goyal to shed some light on the pathological aspects of the case.
Thank you, Dr. Korina. Good morning, teachers. Now I will be discussing the pathological aspect of the sample received in the Department of Oncopathology. On cross-examination, the uterine cavity shows a polypoidal lesion measuring 3.5 cm in the greatest dimension. Multiple fibroids were also identified. Right fallopian tube was dilated, and on third section it shows a growth, and the left fallopian tube lumen was obligated. This was unremarkable. So on microscopic examination of the right fallopian tube, as you can see that this is the wall of the right fallopian tube, this is the serosa, and this is a growth involving the lumen of the right fallopian tube. And this is an invasion, as you can see. And this is a high power view of the same picture, showing the papillary right projections lined by tuboidal to low columnar cells having high NC ratio, nuclear pleomorphism, and containing a fibrovascular core. So it was a diagnosis of invasive papillary serous carcinoma infiltrating the wall of the right fallopian tube was given. In the left fallopian tube, this is the lumen of the left fallopian tube showing a growth which was not infiltrating the wall of the fallopian tube. So it was an intraepithelial serous carcinoma. Final diagnosis which was given was papillary serous carcinoma involving the right fallopian tube with extension into the endometrium, myometrial invasion not seen, serous intraepithelial carcinoma of the left fallopian tube. 12 lymph nodes were identified which were freeform tumors. Bilateral ovaries, cervix and omentum was freeform tumor. Peritoneal fluid shows no malignant cell. So according to the 8 AJCC admission and cap protocols, pathological stage of PT2 and 0 was given. Thank you.
So can you also tell us the grade of the tumor? Low grade, moderate grade?
So it was a high grade tumor, so it's a high NC ratio and nuclear pleomorphism.
High grade tumor,
Yes.
because that is also important for us. Yes, sir.
Also, the polyp, this is an extension.
So the polyp was there and it was showing the serous intraepithelial nucleus, no myometrial invasion.
So that means 3 malignancies, 3 separate malignancies.
So according to the you and colleagues diagnostic criteria, the main lesion is in the fallopian tube. So according to this diagnostic criteria, if the lesion is present in the main lesion is in the fallopian tube, and if the ovaries and endometrium are showing a tumor of smaller volume, so the primary of the fallopian tube is to be considered.
Do you consider this as metastasis or direct extension?
So the endometrium is direct extension, and in the right fallopian tube it was a separate lesion because the corner part was free from tumor.
But it was arising from the anterior wall.
Yeah, anterolateral wall.
The MRI doesn't show involvement of the biometrium at all.
Yeah, so we are also saying that.
How can it be direct extension from the fallopian tube without involving the biometrium and then moving to
It was an intraepithelial.
That is what you said.
Intraepithelial
It was
lesion
an
directly
intraepithelial
from the endometrium of the endosalpinx to the.
But then you have to show that it is as a part of the fallopian tube which is joining the endometrium and it is a direct extension.
Sir, we didn't have that slide.
Actually, the slide.
Slides have already been issued and
was issued to the. They could not project it.
But the larger region seems to be in the endometrium rather than in the fallopian tube.
sir, it was for polyp showing the serous intraepithelial neoplasm, but the invasive foci is in the right fallopian tube.
So that's the point Dr. Rajmohan is asking. Are these two separate malignancies?
But as per the criteria, if it is an invading lesion in the fallopian tube and the myometrium shows non-invasive lesion, so it goes that it is a primary fallopian.
We are agreeing with that. But is there a metastasis from the fallopian tube to the endometrium or are there two separate
Since
distinct?
they were of the same pathology, the guidelines say that it should be taken as a primary. The one which is invading.
Sir, ESMO guidelines say whenever there is a high-grade lesion, most of the times it is metastasis, not the two synchronous lesions.
So I think this patient has a very strong family history, and I think we will come to the genetic analysis which will be done or should be done. And it could jolly well be 3 separate tumors also. So that is not very unusual. And as Dr. Kapoor is saying that we don't have evidence of contiguity spread. So we have, there is a distinct possibility that it could be
Yeah, it can
3
be a
separate idases of malignancy.
You know, is there is to differentiate between metastasis and primary?
ISC. Sir, if it is an endometrial primary, then it will show, if it is an ovarian primary or tubal primary, it will show WT1 positivity. And in endometrium, it will not, it will come patchy positive.
Have we done this?
No, sir.
So, based on the histopathological findings, the final diagnosis came out to be a 65-year-old, para-3 life 3 postmenopausal female with pathological T2N0 primary right fallopian tube cancer with endometrial extension and pre-invasive serous tubal intraepithelial carcinoma lesion in the left fallopian tube. Figure 2021, stage 2A. Now, I would like to call upon Dr. Aarti Kothari to walk you through the primary fallopian tube cancer.
A very good morning to the August gathering. We have all heard about endometrial, cervical and ovarian cancers. But today I would like to discuss a very rare cancer of female genital tract, which is the primary fallopian tube cancer. It is so rare that its incidence is about 3.6 in 1 million women. And since 1888, only 2,000 cases have been documented in literature. We do not have any substantial data for our country that has been documented so far. The median age of diagnosis of primary fallopian tube cancer is around 64 years, and it originates from the transformation of the salpingeal mucosa. Epithelial ovarian cancer is the umbrella term that we use that includes epithelial ovarian cancers, fallopian tube cancers, as well as primary peritoneal cancers. This umbrella term is used because they behave similarly in terms of their dissemination patterns and their response to surgery and chemosensitivity. Talking about the pathophysiology of fallopian tube cancer. Every time a woman ovulates in her lifetime, when the ovum escapes the follicle and reaches the surface of the ovary, there is requirement of release of cytokines and prostaglandins. Every time these cytokines and prostaglandins are released, they cause trauma and insult to the secretory tubal epithelium. That leads to formation of a single cell TP53 mutant epithelial layer and formation of a pre-malignant stick lesion, which is serous tubal intraepithelial carcinoma. These stick lesions can eventually penetrate locally, or they can exfoliate onto the surface of the ovary or form a primary peritoneal cancer. Talking about the increase in incidence of the primary fallopian tube carcinoma. Firstly, with the increased awareness that the precursor lesions of high-grade serous carcinomas usually lie in the fallopian tube when there is a stick lesion present. Secondly, there is adoption of the C-film protocol by the pathologist, which means there is extensive sectioning of the fallopian tube and fimbriae. That has led to an increase in recognition of stick lesions. Thirdly, there is adoption of preventive strategies like risk-reducing bilateral salpingo-oophorectomy or RRBSO in women with a hereditary predisposition towards epithelial ovarian cancers, thereby increasing the detection. And fourthly, lifestyle changes, which includes nulliparity and early age of menarche and late menopause. So now I would like to walk you through the signs and symptoms that can be present in a patient with fallopian tube cancer. These are incorporated in Latzko's trial. Latzko's trial is positive only in 15% of cases with fallopian tube cancers, and it includes intermittent serosyngonous vaginal discharge, colicky abdominal pain, and abdominopelvic mass. In our patient, only these two are seen. Talking about the hereditary pattern and what has been recommended, 20% of women with epithelial ovarian cancers exhibit a genetic predisposition, and 25% of hereditary and breast and ovarian cancer symptoms can be attributed to BRCA mutations. So women with BRCA1 or 2 mutations should consider undergoing risk-reducing bilateral salpingo-oophorectomy between 35 and 40 years as advised by the Society of Gynecological Oncology. Women with DRIP, RAD51C, RAD51B mutations should consider risk-reducing bilateral salpingo-oophorectomy between 45 and 50 years as advised by National Comprehensive Cancer Network (NCCN). And the treatment that we adopt in cases of primary fallopian tube cancers is optimal cytoreduction, that is the mainstay of the treatment. So, total abdominal hysterectomy with bilateral salpingo-oophorectomy, omentectomy, selective pelvic and para-aortic lymphadenectomy, and that is followed with platinum-based chemotherapy. The maintenance can be done by anti-VEGF monoclonal antibodies like bevacizumab and PARP inhibitors. This will further be discussed by Dr. Abhilash, and I would like to welcome him. Thank you.
Thank you, Dr. Aarti. I am Dr. Abhilash from Medical Oncology Department, second year resident. So we have a case of, I would like to outline the treatment of this patient of 65-year-old female who is a case of fallopian tube cancer with stage 2A and with serous histology and with high-grade tumor. So the plan is to give 6 cycles of adjuvant chemotherapy with carboplatin and paclitaxel. And the treatment was given outside hospital, but the treatment, paclitaxel is given 175 mg per meter square. It is given IV. And it is administered on day 1. It is given as an infusion for about 3 hours, and carboplatin is given with AUC of 5 to 6, and it is given IV, and on day 1 it is administered over 30 to 60 minutes. This cycle is repeated over 21 days. So I will briefly outline about the drugs carboplatin and paclitaxel. So the dose of carboplatin is calculated based on the target area under curve based on GFR. We used a curved formula. The formula is carboplatin dose is calculated as AUC into GFR plus 25. So we basically required to do all the baseline investigations, which will be CBC, LFT, RFT, and we also need a detailed clinical examination. A baseline examination is needed, and after every time when chemotherapy is given, we need to check these, because this is dependent on the GFR, etc., GFR and liver functions. So the baseline creatinine clearance is needed to be calculated. Dose reduction is necessary if there is any renal dysfunction. Myelosuppression is basically the major dose-limiting toxicity. Though it is a little bit less emtogenic, less nephrotoxic and less neurotoxic than its sister drug cisplatin, but still precautions need to be taken in that aspect. It is a bit allergic. Its allergicity can be rash or hypotension. It is mild and reversible. It shows mild and reversible elevation in the liver enzyme. So LFT is need to be done on the baseline and after at every next cycle. With paclitaxel, it has a high risk of hypersensitivity reactions, and this hypersensitivity is majorly due to the preservative which is used, which is Cremofor. Dose reduction is needed in liver dysfunction. Myelosuppression is again a dose-limiting toxicity in this with paclitaxel also. It shows a transient asymptomatic bradycardia during the chemotherapy, while the chemotherapy is being given. Acute side effects may be alopecia, immediate side effects like it can show mucositis, diarrhea, transaminitis, etc. But the major problem with paclitaxel is a long-term side effect, which is neurotoxicity, which is mostly a sensory neuropathy it might be seen. So it should be used with caution in patients who are diabetics and patients who are alcoholics. And if the drug is being given with other chemotherapeutic agents like cisplatin, which is also a neurotoxic agent. And drug sequencing, we ideally prefer to give paclitaxel before carboplatin, because carboplatin prevents the elimination of paclitaxel. So then it will lead to increased toxicity of the paclitaxel as it stays more for longer time in the body. So paclitaxel followed by carboplatin. And the other drugs which are used in, which can be used in ovarian cancer are bevacizumab. It is approved for stage 4 and stage 3 majorly, but FDA approval is there for these 2 stages. But it is also used if there is ascites or if there is a high risk group patient. So high risk group is like poor performance status or high grade serous histology, higher pre-treatment CA125 level, or suboptimal surgical site reduction. Dose is usually 15 mg per kg IV, and it is given over 30 to 90 minutes, and it is repeated every 21 days. Side effects associated with bevacizumab are hypertension, proteinuria, neutropenia, thromboembolism, wound adhesions. But the black box warning is gastrointestinal perforation or fistula bleeding. If they are present, it should never be used again. We also use PARP inhibitors for maintenance once the major initial chemotherapy is completed, and if the patient has a good response, a complete response or a partial response, after that we can use PARP inhibitors if the patient is positive for BRCA mutations, or if the patient is positive for homologous recombination defects, which are almost in 50% of these patients. So the drugs available are olaparib, niraparib, and rucaparib. These can be used up to 2 to 3 years, and they are used as a maintenance treatment. They give some benefit in their survival. Thank you. I will come back, Corina, to take the case forward.
Dear colleagues and students, so today's case was having a strong family history here. So when we take a family history, we generally represent the male as the square and female as circle. So we represent by these symbols as male and female, and this is the sign of marriage, and the offsprings are shown here. And when we take a family history, we generally take 3 generation pedigree. We make a 3 generation pedigree. One is above the proband and one is below that proband. So here this one is our proband who came to us with complaints. So she was a person who was having the fallopian tube cancer, and because she has fallopian tube cancer in one fallopian tube and stick lesion in second fallopian tube, so 2 separate tubes were involved.
So we showed like this, and there were multiple family members were affected with cancer in the family, and when they are affected with different kind of cancer, so we should label them with different symbols. So I choose here different colors for those symbols. So one was affected with esophageal cancer, mother was affected with endometrial cancer, and one was sister was affected with breast cancer. One person was died and cancer type was unknown. So multiple type of cancers were there in their family pedigree, and there was most likely it was started from mother and it was given into his offspring. So siblings were affected, and there was also risk for offspring of this person being affected with cancer. So this family should be tested for the cancer genes. So as there are multiple type of cancer, so sometimes there are syndromic cancers, and in that case different type of cancers may present in different family members. So one suspicion is here BRCA group, and second is Lynch syndrome. BRCA is somewhat less likely probability in this family, because in BRCA there are breast and ovarian cancers are most likely, and fallopian tube cancer may happen in BRCA, but upper GI cancer, liver cancer, those are less likely in BRCA. However, in that system pancreatic cancers are common in BRCA carriers also, but not the esophageal cancers and liver cancers. These are very less likely reported. So BRCA is less likely suspicion in this family, and Lynch syndrome is quite suspicion that any of the genes with Lynch syndrome may be the positive gene in this family. So we should test for this Lynch syndrome. However, in Lynch syndrome, common tumor are colorectal cancer, and no one family member is affected with colorectal cancer. So this is also we don't know that this is the cause in this family or no. So the gene in this family is still unknown. So in this family, when we start the workup for the cancer gene, so we can do either the testing from the tumor tissue. So here, and we are thinking of Lynch syndrome, so microsatellite instability testing can be done from tumor tissue, but this tumor tissue testing will only tell about the person who is affected by the cancer, but it will not tell that whether it is hereditary or this mutation is present in only tumor. So if we want to know the hereditary component of the cancer, whether this cancer is hereditary and can be inherited to various family members, then we should do testing from the blood of the patient. So here we can advise the hereditary cancer panel in this patient, so that in this hereditary cancer panel around 70 to 80 genes they sequence in one go, and if any of the gene is having mutation, then they can tell us that this gene is having mutation in that person, and that will help us in the way that if we know the gene, then we can know the asymptomatic carriers in the family, because so many persons are affected with cancer, so their descendants may be carrier for that gene. So if any person is carrier for the gene, we can put on them screening, early screening, we can save them, and the person who is not affected or not carrying the particular gene, then they can be free from anxiety. So in this case, we should do the cancer panel in that patient. However, we have called the patient, she will come and we will counsel her. Now, Dr. Corina.
Now, to discuss the crux of the case, basically primary fallopian tube cancer is extremely rare but should be considered in the differential of peri and postmenopausal women with gynecological complaints. Opportunistic salpingectomy should be done in benign conditions to reduce any further risk of cancer. Women with a hereditary predisposition towards epithelial ovarian cancer should seek counseling by geneticists and consider a risk-reducing bilateral salpingo-oophorectomy. The primary fallopian tube cancer is usually first appreciated by pathologists, so the adoption of CFIN protocol is vital. And lastly, a multidisciplinary approach should be adopted in treating such cases. From our department, a paper was also published in the International Journal of Medical Science and Advanced Clinical Research based on this case. I would like to thank the CCR Review Committee, the Department of Oncopathology, Radiology, Genetics and Medical Oncology for their valuable inputs in this case, and to the Department of Anesthesia as they help us in all the surgeries, and to the patient and the family for helping us to study such a rare case. Thank you.
Next we will kindly do medical genetics. Gene analysis, cancer gene analysis. On next visit, Dr. Rekha?
Yes, sir.
So that we can know that there is one cancer. Today we have few of my friends sitting here and those who have joined also the institution and got awarded also. First of all, I would like to introduce Dr. Nimish Mehta, who has joined as the liver transplant, HPV surgery and the head of the Center for Digestive Disease. The liver tower is coming, so already work is going on. And he is one of the topmost liver surgeon of the country, done independently more than 1,500 liver transplants. So I don't think now, right from the pediatric to adult liver transplant, we need not to look back, and we have a lot of hopes from you. And just like as now we are doing on average 2 kidney transplant every day, so there will be in very short time we should be able to achieve this target, and we should come on the national map. We have done so far 70 plus liver transplants. So I like you to speak few words, Dr. Nimish Mehta. We are grateful to you that you joined finally after 15 years working as a co-chairman in Gangaram Hospital.
Thank you, sir, for those kind words of introduction. I've been fortunate enough to work in some of the best institutes of the country, and I'm joining another premier institute of this country. So thank you, sir, for those kind words. It was under the vision of the Emeritus Chairperson Dr. M.L. Swarankar and the Chairperson Dr. Vikas Swarankar. We started doing liver transplant, our association way back in 2018, before even we set up the Department of GI, HPV and liver transplant. And today, under their guidance and support, I can proudly say that we are one of the leading liver transplant centers in the country. But as sir already has vision for far more, we don't want to stop here. We are going to offer a complex services for complex HPV services, that is hepato, pancreatic and biliary cancer as well as benign cases. Our aim is to develop a multi-organ, abdominal organ transplant institute. We are already doing liver and kidney. We would like to bring in pancreas and intestinal transplantation as well. I have been fortunate enough to do the first intestinal transplant in the country. So we need to bring that. We need to bring that also in our fold. And as sir has already pointed out, our vision is much more. With the help and support from all of you, all my friends, my seniors, my colleagues, I'm sure we'll be able to achieve this. Thank you, sir.
We are really grateful to you, Dr. Nimish. Very humble and down-to-earth person. And worked in the Nair Science Medical College in Mumbai, and then in the top institution, teaching institution of the world. And we are lucky that we are able to do it. Now, one of my senior and very son of my teacher, pharmacological teacher, renowned Dr. P.C. Tandia, teacher of teachers. Dr. Rohit Tandia, who is 2 years senior to me from SMS Medical College, now in the United States, incidentally happened to be here. So I like, sir, you to speak few words. And he is the CE's philanthropy, अभी 75वां वो था Platinum Jubilee celebration of SMS Medical College, and he himself has donated 4 crore plus for the sports arena in the name of his father. So, wonderful sports arena is coming in SMS Medical College, our parents' institution, and it is just because single man effort by Dr. Thank you.
time around because I tend to speak too much. So, be as it may, it is just simply amazing to be here. अभी थोड़ी देर पहले जो आ रहा था तो मैं बोला कि कुछ बोलना पड़ेगा तो मैंने पूछा अपना तो हाउ कैन आई से एनीथिंग, मेरा तो दिमाग चक्कर खा रहा है कि वन मैन इन वन लाइफ टाइम, वन विजन, one man's effort can create something so awesome and unbelievable. I have worked in 4 continents. The only continent I have not worked is Australia. But I have simply never even thought something like this could exist. So this is really amazing, and I'm so honored to be with you and to be here. He called me this morning. He said, "He saw our visit." And he was there right on the dot at 8:15. That is, that tells you that, he's timely, he works, he thinks. So again, it's a pleasure to be here. Now you are all such specialists and super specialists. There's probably a doctor here for the left ring finger and a doctor for the left thumb. And so I'm not going to give you specifics, but I want to just talk to you about a few words on being a doctor. It was Doctor's Day a few weeks back, and I thought about it. I was traveling. I said, if I had to do this all over again, I would be a doctor. And I'm grateful to be a doctor. I'm grateful to be from SMS. SMS का जो ऋण है वो हम कभी चुका नहीं सकते. Knowing what you have to pay and the efforts you have to make to be a doctor in America. So. First thing is, now I've come from America. You expect, I think, me to talk about high technology and machines and blood tests, but I'm going to go backwards and I'll say fundamentals are very important. The fundamentals are the same whether you're a geneticist or an oncologist or an orthopedic surgeon. First is to be available to your patients. That's very important. You may be a great doctor, but if you're not available, then what's the point? Second is you have to spend a little time with the patient. I'm not saying that you don't and I do. We all make these mistakes, but we have to think backwards. कि क्या करना चाहिए. Second is to talk to the patient, spend time with the patient. And someone told me a trick: always touch the patient, so they feel good. And then of course you give good timely care. So being a doctor is a privilege. With privilege comes responsibility. So. I was walking, a few years back I was walking through the streets of New York with my daughter, and a man, I don't know what happened, but he fell down, he got sick. I just walked past, you think कि भाई मजे आ रहे हैं, बेटी के संग घूम रहे हैं, and who wants to just get involved with things that you really have no business. So my daughter got very upset with me. I said, why are you upset? But she said, Dad, you were walking by and you just walked by and you didn't take care of this patient. I said, I was with you, I don't have a license of the state, and I just wanted to move along. He says, no, I don't accept that. I'm very disappointed in you. And so that got me thinking, it is a privilege to be a doctor, but with the privilege comes responsibility. Once a doctor, always a doctor. So please remember that, the society expects us to take care of them. Lastly, physician, heal thyself. We should take care of ourselves. We tend always to worry about our patients, run around, start at 6 in the morning, finish at 9 or such. We need to take care of ourselves, we need to take care of our mental health, we need to take care of our physical health. And you know how to do that, but so that. And lastly, I want to tell you about a very important Indian-American physician. His name is Abraham Verghese. He was in fact invited to the big dinner that President Biden did for Modi. He's written many good books. And he's a professor of ethics, theory of medicine and internal medicine at top university in Stanford. So he says many things. The one thing that struck me about him, he says, what is the treatment that you can give to a sick patient in the emergency room from the ear? So that's sort of a trick question. He says, kind words and support. So please remember, kind words, support will always go a long way. Thank you for having me here. Thank
you, Dr. Rohit Gandiaji. We are honored and privileged to have you this morning. And now I invite Dr. Nitin Kuteta. He got the award on the National Doctors Day. Only 25 people, doctors in the country got the award. And from Rajasthan, we got dental city. So there is inauguration at 10:30 in the dental college for the full-fledged dental city scheme. So all of you are invited, those who are free. Naren Padiyar is there. He can tell about what are in July. There is a Let Us Talk About Death seminar is there. So we request you to participate in that also. And Dr. Hemant Malhotra is doing a lot of work, and we have the whole show, and a lot of good speakers will be there. So, these things are very important. We should always encourage academic activities.
Thank you, sir, for this opportunity. First and foremost, I cordially welcome all senior faculty and other PG residents to visit Dental College, and for today's inauguration at 10:30 a.m. This CT machine is a slight modification of the technology of the regular CT. This is called cone beam CT, where the exposure, the radiation exposure is almost 1/10 of the regular CT, and with the better resolution. This machine is having a field of view of 18 by 16 centimeters, which takes care of the entire maxillofacial region, which includes even investigation of ENT, that is the inner ear, and cervical spine, and we can also do the airway analysis for sleep apnea patients, and this is even for clinical work and also for research oriented. Other than this, for routine dental, all applications, we can use this CT machine. The maximum scan time is around 20 seconds, and only thing is the patient has to be in a standing position, and I hope even many of the medical patients, ENT and neurosurgery, can benefit from this, other than so this particular machine is getting very popular nowadays. Even standalone dental clinics are going for it. I think in Jaipur we have at least 15 machines, and in Jaipur we are the 3rd dental college, but we have the highest FOB machine in our institution, and the SMS, that is the RHS Dental College, installed this machine quite a long time back, of course being a government institution, and I'm sure the quality of treatment will improve immensely with this addition of, and I sincerely thank Dr. Swanjar sir, Vikas Swanjar sir, Ramratan Soni sir, and Yogendra ji, who have been instrumental in bringing this to our institution. Thank you very much.